Hey everyone, this is Dr. Angela Scopel-Levick, and I'm so excited for you guys to join me today regarding this topic on the vagal tone and using the GI map. Before we jump into it, I just want to mention that, my point of this webinar today is really to excite you guys about things you can apply next day into clinic that hopefully take some of the pressure off of you as the clinician. What I'm going to give to you today is really going to allow you to get to know your patient literally inside and out, and how they perceive the world around them and how that affects their digestive system, but also other organ systems, which will take some of that pressure off of you when you're trying to get to the root cause. So we're going to jump right into it. We're going to talk about targeting bloating, motility, and inflammation using vagal tone modalities with the GI map. So we're going to start with just a little bit of background information. Most of you guys are aware of the autonomic nervous system, but it's always good to recap as it's kind of the foundation of today's webinar. So we have both the sympathetic and the parasympathetic, which are branches of the autonomic nervous system. And what is interesting is that most people do not know when their body is in a high sympathetic versus parasympathetic state. Most of the time, our body is not in one extreme versus the other. It's kind of this middle ground between both of them. But it's going to help you as a clinician when you can identify, your patient being in one extreme of sympathetic or one extreme of parasympathetic, to help you kind of, again, get to that root cause, but also to make the most of your limited time with them in practice. I mean, let's be honest, we have, some doctors are at a 15 to 20 minute cutoff with their patients, and you really want your patient to feel validated. You want them to know that they are heard. And a lot of times when you are aware of these symptoms through listening to what they're saying, but also visualizing changes on them in person, you're able to gather more information about what's going on inside their body and, again, how they're responding to the world around them. So in the sympathetic state, which you see here on the left in the red, we have this like run from a bear state. So this is, if we go back to our ancestors, I mean, literally they had to, run from predators. They had to keep themselves safe. And when they did that, they were in this high sympathetic state. So in that state, our body is not focused on digestion. It's the last thing our body is actually focused on. More so in that state, our body is trying to pump as much blood flow out to the peripheral, to the muscles, so that we can run faster. If you see here in the sympathetic state, your eyes are the pupils are going to dilate, and that's so that you can see, danger ahead. You have dilated bronchioles to get better oxygen in so that you can actually have better endurance and maintain the run. Your heart rate's going to speed up. So you see this sympathetic side. Again, we describe it as like running from a bear. And then parasympathetic is your rest and digest. So in rest and digest, imagine our ancestors, they're safe. I think more like hibernation winter when their, food is stored up and they are in this place, they're hunkered down. They're in this long-term rest and digest state. So they get constriction through the pupils, constriction of the bronchioles, slowing down in their heart rate. They have increased secretion through the digestive tract, increased motility. That allows them to better absorb the nutrients that they're eating. Like I said, think of like hibernation, like they're storing up. So they're absorbing all of those nutrients, right? So this is kind of just a quick background on that. And what I want to point out really is, as the clinician, what you're going to look for in say your appointment with your patient is potentially a patient complaining of dry eyes, dry mouth. You hear things like that. I want you to snap those kind of phrases of, okay, what's this person's autonomic nervous system doing? I'm thinking dry eyes, dry mouth. This is probably more a sympathetic state. Their body is not really worried about lubricating the joints and secreting, those kinds of fluids in a more of a sympathetic state. You might actually see enlarged pupils on your patient. You may pick up on shallow breathing, more of like this shallow, maybe chest breathing versus like this, which we'll talk about, but this diaphragmatic, belly breathing. You might also see like them actually having sweating or complaining about like pervasive sweating in your office. We all know the white coat syndrome. It's a real thing. It sends your patient into that sympathetic state. So I really want you to re-explore this. This is kind of the foundation of what we're going to be talking about today. And so let's jump into this next slide and go a little bit deeper into the autonomic nervous system. So we're going to talk about the polyvagal theory. Now, this might be something newer to you. Some of you are familiar with it. Everyone kind of knows about the sympathetic and parasympathetic, but this polyvagal theory is so key. It was developed in 1995 by Stephen Porges. And so it's this neurophysiological model that helps us understand the autonomic nervous system and how it regulates, I should say, the body's response to feeling safe or unsafe. So you might even be, thinking, okay, what does that have to do with my patient's, let's say digestive pathology or dysfunction? Well, I would say it has so much to do, because remember that everything outside of us is basically some type of insult to our bodies, to our autonomic nervous system. And when I say that, I mean it's how we perceive it. Is it safe or is it unsafe? So this theory suggests that feelings are higher brain interpretations of neuron signals from visceral organs such as the gut. And so I want you to take a moment with me and just, before we dive into the figure that's here, understand that this model has been used to interpret the relationship between IBS and HRV. So we're going to dive into HRV, but just as a brief explanation, that is your heart rate variability, and it is used to identify vagal. It can be used to have more of an inside look at vagal tone, I should say. So vagal tone is understanding the degree of your vagal nerve and how well it's working. And so this model, if you think about it, we all have those IBS patients, and even the research will back this up to show that they have higher incident rates of high anxiety, high depression, and typically some kind of trauma that goes into their story of the IBS. And so when you think about this polyvagal theory and you think about this model, it actually helps you understand, okay, this patient is being sent into this potentially like sympathetic mode, or bouncing between the extreme of the sympathetic and parasympathetic mode based on, again, their response to the world around them. So let me give you an example. I literally was this week had a patient who was diagnosed with IBS. She told me, oh yeah, I was told that before. And it always throws me by surprise, because I'm like, okay, well, what did that mean to you? Or what did you do in regards to that? And a lot of times I will hear, and she kind of validated the same thing of like, well, they didn't give me an answer as to what was the root cause. And so I just kind of, attributed that to this is me. And this is what, how my body is. And I said, well, explain to me what your symptom is. And she said, well, I would, my recent example of this is I was driving, taking my daughter to drop her off. I share custody with my ex-husband. And, driving down the road, I had to pull off and use her potty because I had such bad diarrhea. And she said, that's normal. Like, I literally have to use, my daughter's potty often in those cases. And I thought, man, this is not okay. But beyond that, what really set into me as a clinician was, okay, she's perceiving, she's anticipating. This is going to be a rough drop off. There's so many feelings and emotions that go into that. And her gut, remember this theory suggests that these feelings are higher brain interpretations of neuron signals from the visceral organs. So that perception of what was about to happen, that perceived future moment, sent her body into this cycle, which we're going to talk about here in this figure, this gut-brain axis, but sent her body into that cycle that triggered having this diarrhea. Now, there were other things, I do use the GI map, and we're going to talk about that. So there were some other bacteria that were like big histamine drivers with her. But as a clinician, I hope you can understand helping validate your patient to say, yes, you perceived something outside of your body that started this triggering effect inside your body. Okay, so this model is huge, not just for IBS, but that's one of them that I think you guys probably come across often in your office. So I wanted you to understand that connection. Now let's go to this model here for a second. So this is your gut-brain axis, and I'm going to go into more detail, but you have basically these red limbs, which are your vagal efferents with an E, so vagal efferents. And if you don't know what that word efferent means, think of like motor or outputs. So coming from the brain, number 5 and 6, you see these vagal efferents. And then 1, 2, and 3, as you kind of come back around, these are vagal afferents or sensory neurons, okay? So you have this direction. Now, this is a bidirectional. It can go from gut to brain or brain to gut. So it's bidirectional. But essentially, let's go through like this example I just gave you of someone who perceives some kind of outside stressor or moment or future moment. And there's hormones. There's cortisol hormones. There's other hormones that are released from the brain, other neurotransmitters. They go through this HPA axis. As you can see, these hormones get released. And then as they kind of swing around here to number 2, you see how the gut then reads these hormones. There's receptors there, those vagal nerve receptors, and it picks up on these chemical, hormones, neurotransmitters, even cytokines can be picked up here. And it will bring that information back through, to the brain. Now, limb number 1 is specifically showing you that immune system. So if there's an inflammatory cytokine response, the gut is going to pick up on that and send a signal back to the brain. That inflammatory cytokine response could be, let's just consider that's from something like IBS, the inflammatory condition that comes with it. Maybe there's this pathway, could be from a food trigger, like an inflammatory food trigger. We all know that with histamine, we tend to be a little bit more sensitive to certain foods. One of those could be dairy. Say the patient eats like this high triggering food, the immune system senses that, you get this release of cytokines. That's triggered back to the brain, okay? And then what about gut peptides? We'll talk a little bit more about this, but this would be like your, GLP-1 inhibitors potentially here, and how that signals back to the brain. And then number 3 being, which I already mentioned, but some of your neurotransmitters being signaled back to the brain. So you have this pathway, okay? And then B here is just demonstrating some of the pathologies or dysfunctions that we tend to see come from this bidirectional pathway, and how it can be triggered through some of those responses. So lastly, about the polyvagal theory, what I want you to understand is don't just think IBS. I just wanted to give you that example. But this model can actually help you also individualize your patient's treatment plans. Every patient wants to be heard. Like I said, they want to be validated. They want to know that you're just not treating them like every other IBS patient. And so when you understand this model, you can understand like, oh, you're having, this immune response or this neurotransmitter response. And that's how you can kind of individualize your patient's care, and also know, if they give you insights into what is perceived stressors for them, being able to determine like, hey, you might not even be ready to do, the protocol that I want to do for you, let's say based off the GI map, because you're stuck in this, sympathetic state. You may not be able to handle an additional stressor on your gut. And so using this theory, patients love that. I mean, some of you guys may be like, why would I ever not do a protocol that I think is going to help my patient? And it's like, no, you're going to do the protocol, but maybe slowing down the treatment plan and getting them to understand like, hey, we got to get a grip on this first. We got to really go back and do some stress management, some vagal tone work, so that you can actually even respond to my protocol that may help you with other findings that we're finding on diagnostic imaging. So then we're going to go to the human microbiome dysbiosis model. This is just a big picture. Again, we're going to dive into the nitty gritty, but I just had to expand so that you could see, this gut-brain axis is so tied into all of these organ systems. For instance, you guys just heard me talk about, gut peptides. And so we can jump to this metabolism, green picture here on the dysbiosis model, and think about the GLP-1 inhibitors that are so popular now to help with, yes, diabetes, but just also weight loss. And knowing that the vagal nerve is actually the main nerve that is involved with satiety. So in those GLP-1 inhibitors, it's basically inhibiting that vagal response, making people, not as hungry. That's one of the things that you hear is like, man, I can control my hunger levels more. Okay, so now you as a clinician can explain that, like, this is how it's working. So just like understanding this huge connection. And that's why we encourage you, if you are a clinician, running the GI map, that you're thinking outside the box. If you've got a patient with psoriasis, if you've got, a patient with autism, the GI map or using, that further diagnostic image to see the gut and the gut microbiome is going to be so helpful. So we're going to start with location and function. Again, just a little bit of a deeper dive so that you can understand exactly where these vagal afferents are located and how they respond. So another picture at this gut-brain axis, like I said, this one might be a little bit better for you to understand that vagus nerve being one of the main communicators between the gut and the brain. So if you didn't pick that up on the last model, this is a good model to kind of let your brain sink that in a little bit. And so as we're talking about this vagus nerve connection, what I want you to understand is you've got these vagal afferents, which I showed you on the previous figure. And where are they located? They're highly prevalent in the upper GI tract. So they have a lower, it doesn't mean, I should say this, that they're not present at all in the lower GI tract, but they lose like their density as you kind of go down the GI tract. And so their action is going to be more around the threshold, like a low threshold of activation. So your everyday physiological regulation. What that means is if you eat a bolus of food, there has to be a response to that bolus of food with the muscles of the gut. There has to be a tension and stretch response that happens, and there has to be a chemical response that happens. So these low level thresholds that happen all the time that we don't even think about, that's your, vagal afferents in the upper GI tract. And then in the lower GI tract, it's densely innervated by spinal afferents, and those are a little bit more responsive to the noxious levels of stimuli, or I think of pain. And to take even a deeper dive into that, you have this vagus nerve signaling. I thought that this was so helpful because it kind of zooms in on the gut here, and you can see, let's talk about the vagal chemoreceptors first. So these vagal chemoreceptors, you guys see the two pictures that say nutrients on each side of the gut lining here. So that's going to be more insight of the vagal chemoreceptors. So essentially you have, you eat a meal, so you've got, certain nutrients that you absorb through the meal. And those nutrients basically are going to signal in the gut cell. It's called your enteroendocrine cells. That's the EEC. So those nutrients kind of signal these enteroendocrine cells. And basically they express nutrients on these receptors of the EEC. And then when activated, they initiate an intracellular process which involves release of gut hormones like CCK, the GLP-1, which is the glucagon-like peptide one. So you've got this release, right, of these nutrient receptors being expressed, and you can see the vagal afferents are right there, right within close proximity, getting that information. And so these chemoreceptors, or these vagal afferent chemoreceptors, are responding in real time to gut hormones, nutrients, osmolality, and pH change, from the meal that you just ate. So that's your chemoreceptor, function there. And then you've got the vagal mechanoreceptors, I should say, that are down below. There's several of them. There's the intraganglionic laminar endings, the IGLEs. There's the that are involved in tension receptors. There's the IMAs, which are your intramuscular arrays, and they're involved in more the stretch sensitive receptor part. And then you have the tension mucosal afferents in the brown here that I think is so interesting. They're sensitive to mucosal stroking and stretch. So what that does is it helps detect food in the stomach, such as its size and its chemical composition. So, look at the complexity here, or the involvement of both these chemical and mechanical receptors in the gut lining in response to, what you're eating. But furthermore, also like the chemical receptors, the hormones that your body is releasing, the neurotransmitters and whatnot to, again, the world around you, right? And so I want you guys to think with the chemical receptors, think of inflammation, because think of chemicals that they're releasing. Think of certain neurotransmitters that are going to stimulate inflammation. This webinar is about motility and inflammation and bloating. So when you have disruption of the chemoreceptors, you're going to see, inflammation take place. When you have disruption of the mechanical receptors, you might see, more this bloating and overall distension look. And then I don't want to pass up just an opportunity to talk about this anti-inflammatory cholinergic vagal pathway, because again, this is so important to understand how inflammation, and you see this on the GI maps, which we're going to show you some, but man, the inflammation, how when you see this outrageous inflammation that it's like, man, your body is not working to dampen this at all, that could be a problem with the vagal tone. And so this pathway, let's go over this. You've got the brain here. You've got your vagal efferent nerves, right? So those guys are going to talk through the splenic nerve. So you've got this vagal splenic nerve pathway. So you'll get this release of neurotransmitters through this pathway into the spleen. And these chemicals then bind to immune cells in the spleen, which can alter the immune function. So you see here, you've got the splenic nerve, you've got this norepinephrine release, which is going to activate more of your T cell. It's going to release acetylcholine. And then from that macrophage, you're going to get this expression of cytokines, again, taken back to the brain for physiological response, right? So remember this pathway. We're going to talk about it a lot, but I wanted to kind of hone in on it. And I want to remind you that stress inhibits this pathway. So stress inhibits the vagal nerve, and it has a negative effect on the gastrointestinal tract and on the microbiota. And it is involved in the pathophysiological side of a lot of your pathologies like IBS, and even, remember, we're going to go into this, but functional dyspepsia too. So I hope this kind of helps you guys outline that inflammatory response. Now, for some of you, you're more graph-oriented or chart-oriented, so I put this here if you needed to snap a picture of where these endings are in the esophagus, the stomach, the small intestine, and a lot of it we talked about, the visceral endings, like the IGLEs and the IMAs, where they're a little bit more dense. You see the nucleus tractus solitarius and the brainstem that has a big role in this vagal response. Your primary response to stimuli, we talked about the mechanical receptors, the chemoreceptors. And so I just thought this would be good for you guys if you wanted maybe it in a chart. So now we're going to go to clinical application, which I know you guys all love. I do too. So now it's kind of like, how can we apply this in some of the pathologies we're seeing in our patients? So I mentioned to you guys functional dyspepsia. It's a common GI disorder that causes pain, discomfort, and upset stomach in the upper abdomen near the ribs. And symptoms typically are like epigastric pain, burning, postprandial fullness, early satiety, and bloating that your patient's going to complain about. I'm sure you guys have all seen this picture in your clinic, but I want to take a deep dive. Let's look at this image to the right here. And let me kind of explain this first. So you've got this gut-brain axis, right? So this bidirectional axis that we've kind of taken a deep dive into. And what happens is, follow me, on the right you have the mechanico-sensitive vagal afferent. So remember, that's sensory. On the left you have more your vagal efferent, so that's kind of motor or output. And the physiological state is the blue arrows. And then we'll dive into the functional dyspepsia in a moment. But in the physiological state, normal physiological function, you would eat a bolus of food. So you'd have a meal. That bolus of food gets into the GI tract, and you have this mechanical response, right? Those stretch and tension receptors that give feedback in normal physiological function to the brain. So if you go up to the right-hand side of this image, you see fullness, and you see a blue arrow. So that's normal physiological levels that are signaled back to the brain of like, hey, I'm getting full. So the physiological behavior that follows in the same level of intensity is going to be, hey, I'm going to stop eating. I'm feeling full. I'm going to stop eating. And so therefore you get, no pain. If you look at the lower part of the left side of this image, you get proper gastric accommodation. So remember I said stretch and tension receptors. You get normal gastric emptying, and then you get decreased duodenal motility. So what that is it allows for proper timing for nutrient absorption, right? So that you have proper nutrient absorption taking place. So that's the physiological state, that's normal. When you have functional dyspepsia, you have this hypersensitivity to this pathway where you eat a bolus of food. So now we're going to go back up to the fullness in the right-hand side. And you eat this bolus of food and you have this hypersensitive stretch and tension response. So almost instantly, because there's this hyper awareness and hypertension response in the GI tract and the muscular part of the GI tract, you get this overreactive physiological behavior, which is I'm going to stop eating, maybe halfway into the meal or even before then. And then you get this hypersensitive pain response that follows that. So that's that like either postprandial fullness or people that can't even finish a full meal. And then on the other side of that, the gastric accommodation, it's there, but it's much less. You see that orange arrow being much smaller. And you get gastric emptying that, again, is there, but it's much less. But you also get the duodenal motility being much less. So you're really not getting much accommodation, much emptying. it's there, but it's very little. And you also don't get then that proper rate of motility to help with proper nutrient absorption. And then sometimes that lack of nutrients just feeds back in to this loop. Okay, so this is the mechanical stimuli to this. And then follow with me, we're going to go into the chemical stimuli. So the chemical stimuli, it's the same image that we just ran through, but what I want you to pay attention to is, now that we're talking about the more chemical response to this, what you're going to see is chemical stimuli like CCK. So CCK is going to, if you follow me, you'll see up in the right-hand corner, we now added a nausea and vomiting response, and you see this arrow in the functional dyspepsia being even higher. So that CCK, because of this hypersensitivity, it's exacerbated, and CCK can cause this increased nausea and vomiting response. With this additional chemical stimuli, that chemical stimuli is associated with increased gastroduodenal permeability, infiltration of eosinophil and mast cells, altered microbiota profile, and increased chemical stimuli, which may enhance vagal afferent signals to the brain, contributing to the increased feelings of fullness, psychological behaviors, pain sensations, nausea and vomiting. All of this is your typical functional dyspepsia. So I hope that kind of now also will give you a different picture when you're talking to these patients. And I think what's also interesting is functional dyspepsia patients have increased exposure of acid in the duodenum, which is probably due to the delayed clearance of acid from the duodenum. So, man, eye-opening, isn't it? So then we're going to jump into what causes vagal nerve damage. I think this is so essential. We've talked about some, again, of the background, like, okay, where is this bidirectional pathway? You know, where are these receptors? How does it kind of apply clinically for us? Why do we even want to know about this? And now I want to dive into just what causes this damage, because really you want your patient to understand how they got here. So there are certain diseases, obviously, like diabetes, viral infections. Surgery definitely can also change this. Trauma is a big one. It's not the only one, but it can be. It could be external trauma, but it could also be like internal trauma, like I have here, such as compressions from large tumors. You know, definitely even think about tumors that lie near the vagal nerve. Maybe you're thinking of, the thyroid or, in that area. Remember the vagal nerve, and I'll say this real quick, when I'm working with my patients in my own clinic, I will have them actually outline the vagus nerve on them. I have them take their hand, an open palm, and I have them place it at the base of their neck in the back where their hairline ends. And I have them take their other hand and meet that hand. And with the hand, let's say they're holding their head on the right side underneath the hairline. With the left hand, I have them trace from that hand, around to the side of the neck, all the way down to the heart and the stomach. Sometimes, and I'll talk about this, I have them do that just to ground themselves and center themselves. But if you realize where that's running, having some tumors in that area or things that are causing large compressions, cysts, nodules, whatever, that can also cause damage here. And then obviously prolonged stress, whether that's physical or mental stress. I've talked a lot about external perceived stress, but there's also physical stressors. I spent a long time working with athletes in the beginning part of my career, and having that physical prolonged stress, which I'm going to mention again later in the webinar, but that also plays a big role in overall vagal nerve damage. So what are symptoms of vagal nerve dysfunction? Man, there's a list, and I don't even know that I got to all of them, but you can see here, some of the obvious ones I would say would be hoarseness, again, and that would be hoarseness in the voice with no unexplained reason. Sometimes there can be, vocal cord damage, and so you can understand that. But sometimes you'll catch it, just in a phone call with a patient or in office. And then symptoms that they could report to you, like difficulty swallowing. That could also be something else, but I definitely want you to consider, again, difficulty swallowing that maybe comes out of nowhere. You can't really link it back to anything that you're finding on the test. Could that be more vagal nerve dysfunction? I'm not going to read through all of these. We're going to talk about them kind of a little bit deeper as we go through the webinar, but here are definitely some symptoms of vagal nerve dysfunction. Think of your chronic inflammatory conditions, your chronic fatigue syndrome. Yes, make sure you take note of this. And I don't want to leave out kids. Man, I do see a lot of kids in my own clinic here, and I put this one on here because kids can't always talk for themselves. They really don't know how to put what they're feeling into words that make sense to us as clinicians. They don't know how to say, oh, it's tingling or it's numb or it's throbbing, so when you see whether you're taking, vitals, which I assume you guys all are, but again, like seeing things like even their, pupil dilation and whatnot, their facial expressions, man, you can literally, I'm sure you guys have heard of people doing like tapping to help with their overall stress response. And that's because the nerves that innervate the face, there's such a tie-in to just gentle stroking of those muscles around the face to help calm somebody down. I think we if you really pay attention, you'll notice that people do tend to touch their face or fidget a lot when they are anxious. And some of those are just naturally we're drawn to, putting our hands in certain areas on our face to help us. Actually, what we're doing is we're trying to regulate our nervous system. And so you may see certain facial expressions in kids. They may not be able to have specific eye contact with you. These are things that I want you to remember because it's so important to be able to help them regulate themselves. For sure. I think of even, infants after birth, and I think of the benefit of getting their nervous system regulated immediately within those first, few hours to days of their life and how that affects them, down the road. So further, if you're, someone who does see a lot of peds and you're seeing colicky infants or just babies that are, the mom is like, I just can't, I can't do anything to get this child to kind of settle down, to take naps, to sleep. Yes, there could be other things, but I guess the chiropractor side in me is just trying to let you guys know, like, there could be just such a big autonomic shift. And if you help regulate that, it can actually make a world of change for them and the mother. So now I want to talk about identifying vagal tone influence in our 3 patterns on the GI map. So we have 3 patterns. If you guys are not aware, make sure that you go back to our guide. We list them. We have the inflammatory dysbiosis, digestive dysbiosis, and insufficiency dysbiosis. So these are on the interpretive guide towards the end of the guide. And they're really what I've based my entire practice around in the beginning. Like when I first started using the GI map, these patterns were lifesavers because it helped me interpret the GI map so easily and use it the next day. So what I want to do is dive into these patterns and how do you identify vagal tone deficiency on these patterns. So let's start with the insufficiency dysbiosis. So insufficiency dysbiosis is pretty clear cut in the sense that you're going to see just this lack of good bacteria, which is on like page 2 of the GI map. And we typically, what I want to remind you is typically with these patients, it's interesting, but there is a stressor if you dig deep enough and you ask the right questions. So I encourage you, when you see that, yes, it could be that the patient, was just on antibiotics. That's an obvious one, or they were on PPIs, for long term. That can bring the good bacteria down. But I also want you to ask some other questions, like, and experience this. Like, you get to know your patients, you get to talk to them. Are they a type A? But also ask them, do you guys have, one of the questions I ask, I should say, is like, what's your window of capacity? And patients might look at me and be like, what do you mean? What is that? But it's like, how quick are you to tick if someone says something to you, or if a stressor comes up at work, like a huge meeting is put on your plate last minute, like how fast are you going to tick or kind of want to dive off the deep end? And they'll respond to me and tell me, and I get an idea of like, okay, their window of capacity is so low. So this is a very stressed out person and probably chronically stressed. So these people tend to have, we see increased intestinal permeability. They also tend to have these chronic inflammatory conditions. But what I really want to point your attention to, beyond just the dysbiosis itself, the pattern, is what are we going to identify if we're trying to seek out their vagal tone? So research does show that people with a lower vagal tone are going to have less short-chain fatty acid producers. They're going to have a decrease in the lactobacillus profile that you see there. The Ruminococciae is going to be, that's like your Faecalibacterium, Roseberia, Firmicutes that you see here in the insufficiency pattern. You're going to have a lack of those guys, okay? You're also going to have certain bacteria like Escherichia coli and Bifidobacterium longum that, if they're lacking, so if I should say this, if they're present, they activate the vagus nerve, which we want, but if they're lacking, you're going to have this decreased response from the vagus nerve so that this patient will actually just have a harder time finding homeostasis. So the other thing that you could see is chronically elevated zonulin levels, and that goes back to that cholinergic anti-inflammatory pathway that I talked to you about. Remember that the vagus nerve, its job is to dampen the inflammatory response. So stress inhibits the vagal nerve and can have negative effects on the GI tract. And we typically, I think I've already mentioned this quite a bit, but we see that a little bit more in, I think of like IBS, IBD, patients that kind of favor that peripheral inflammation. So this is your insufficiency dysbiosis and how you would identify some of the vagal tone on that. And I put here, I want you guys to think about inflammation. So again, the topic here is inflammation, motility, and bloating. Think about inflammation because that cholinergic pathway is not being dampened in these guys. Think of bloating because, again, they have that lack of the chemo and mechanoreceptors being activated. We talked about that. And then typically on this one, not always, remember there's no like cut dry, but typically you'll see a little bit more constipation because the lack of metabolites coming off of these bacteria that help with motility, right? So huge red flags there that I think you can identify. And then when we go to inflammatory dysbiosis, so this pattern, you typically are going to see these higher levels of inflammatory microbes on page 3, like Pseudomonas, Citrobacter, Klebsiella, Proteus. And these guys are known to give off high levels of lipopolysaccharides and endotoxins. So here's the beauty of this is, yes, that happens. We have this huge inflammatory response from these bacteria, on page 3. But the vagus nerve, if it's working, in its entirety, should be able to, again, dampen that inflammatory response. So what I love the most is when I have people that I've got several GI maps on, because remember, you can do one GI map and it's just a one-time look, but you get several of these GI maps from repeat testing, or, if you have patients that do these annually, and you can see like, okay, you are just chronically inflamed. That can also show you over time, like this person is having a really hard time, dampening that inflammatory effect from these bacteria. Or what's interesting, so that's one case where I see this, but then another case is, man, I've seen people with high Citrobacter, high Pseudomonas, I'd say E10 Pseudomonas, really, and their symptoms are like, they walk into your office, they're like, doc, I'm doing just fine. And the clinicians, I'm on the clinical team, I'll hear them say like, this patient, man, I never expected to see this GI map result. How do you explain that? Well, consider their vagal tone. They might actually have a stronger vagal tone to where their window of capacity is greater, right? So that's really interesting to me, and I wanted to point that out to you as well. So again, you're going to think inflammation and pain with these people with a vagal tone that's not ideal. You're going to think bloating and potentially, not always, like I said, I'm not saying this is an exact textbook, but a little bit more diarrhea because of the amount of endotoxins and lipopolysaccharides coming off of those big, potentially, not all of them, but maybe you have like a high histamine patient, like we talked about before, my patient with IBS. So yes, definitely symptoms here that you can see. And then you have your digestive dysbiosis. So 2 things I want to point out with this dysbiosis pattern is, one, H. pylori is not always involved in the digestive dysbiosis pattern, but it's there quite a bit of the time. And so in general, when I explain H. pylori to my patients, I'm telling them this is the stress bug. And it's the truth, because when people are in more of a sympathetic state, that fight and flight or run from a bear state, H. pylori loves that autonomic nervous system state. So when you see H. pylori, you might want to automatically think like, okay, it might not be in the moment, because the patient may say to you like, oh, right now I feel great. I'm retired, or like I just moved into my new house, I'm excited, or I just got a new job, I'm excited. But it's like, okay, what led up to that? What was the chronic stressor? Maybe it was the anticipation of all of those things, but there was a stressor typically that autonomic nervous system couldn't control, and it fed into this H. pylori pattern. So that's one thing to think about. But then the other thing is to really draw to your attention the importance of a really healthy mucosal barrier or mucus layer in the gut, because what it does is it serves as a physical barrier. So having a proper maintenance, or I should say proper, nutrient and digestive pH, osmolality, all that supplies a proper mucus bicarbonate barrier, literally research says can be like, one of the determining factors of whether someone has this H. pylori overgrowth or infection versus someone who doesn't. And that's because the vagus nerve stimulation is associated with protective effect on the epithelium and stimulating bicarbonate transport and expression of occluding via nicotinic acetylcholine receptors. So such a huge concept here, I think, for you to digest. And I see this more often than not. Everyone wants to treat the bacteria. And yes, you do. You need to treat the bacteria. But you have to remember the autonomic state. And if we get to the case today, I'm going to show you this inside look at this and how you can even see it looking at the elastase. I bet a lot of you see when you treat H. pylori, you run a repeat test and you see the elastase drop down. And you're like, what happened? I just treated the H. pylori, it's gone, and now their elastase 1 is like below 200, or it's worse than what it was. Because we think that if we get rid of the bacteria, man, those digestive juices are going to bounce back. But what we forget is, no, there was a lot of probably autonomic nervous system dysfunction leading up to that overgrowth of H. pylori. And now that it's gone, great, but you still have to rebalance this patient's autonomic nervous system to get digestive juices flowing again and to get that proper, osmolality and pH balance. So again, here, think of inflammation and pain due to the lack of digestion, bloating due to the lack of those chemo and mechanoreceptors we talked about, and H. pylori can usually go, either way depending on what's growing with it as far as motility. So now, how are we going to measure vagal nerve function? We do this with, a lot of people are familiar with HRV. And so HRV is heart rate variability. And a couple things I want to mention about it. A lot of studies will use HRV actually when tracking vagal tone or reporting vagal tone. But vagal tone, you've heard me say that word a lot. So there's the vagal nerve, but vagal tone is a measure of how well the vagus nerve is functioning. And it can be measured indirectly by tracking HRV or heart rate and breathing rate simultaneously. So the difference between your heart rate when you inhale and exhale is called heart rate variability. And the larger the difference, the higher your vagal tone. So we can use HRV to give us insight. The vagus nerve is dampened or shut off during inhalation, but it's turned up during exhalation. And so therefore it's tied to our respiration and overall cardiovascular health. So that might also help you understand how we can utilize HRV to help us identify someone's vagal tone function. But what I also want to remind you is HRV alone is not just the answer. I think we've gotten a little ahead of ourselves when everyone's like monitoring their HRV, but man, I've seen people with terrible vagal tone because they have all the other signs of it and they have, a really normal or good HRV. And that's because there's a huge genetic variability in HRV. So it's really best to take, like any clinician should, a lot of data or many diagnostic tools to help you kind of come to a conclusion. So you could use HRV, but it's really beneficial if you pair it with VO2 max. And that's because physical fitness is strongly associated with vagal modulation, and VO2 max is a measure of physical fitness by maximal oxygen uptake during exercise. So using not just one marker, but potentially two could be a lot stronger to get an inside look at someone's not HRV, or vagal tone. And then we can also get insight of the vagus nerve through the gut microbiome. So you guys just went through the 3 dysbiosis patterns that we have on the GI map. And so what you're looking for, let's say you do have someone that has, they're recording their HRV. That's great. They bring it to you in the office. They're like, hey, doc, look, this is my numbers. They're amazing. But let's say you do a GI map on them. And I'm just going to kind of repeat some of what we just talked about, but then you see like this lack of microbial diversity. Maybe you have an insufficiency pattern. Maybe you're really low in those short chain fatty acid producers. maybe you've got this, zonulin that's through the roof, and two GI map tests, it's not coming down, systemic inflammatory pattern on the GI map, like that could be a little bit of insight further to kind of help you understand. So looking at the gut microbiome is actually a really good way to get some insight through or of the vagus nerve. And then what about, just posture analysis? So the chiropractor in me had to put this here, but I think it's so important because it's so simple. What if you're like, man, I don't monitor HRV and I don't do VO2 max in my office. Like, how do you want me to apply this? Well, let's look here. So in this model, you have normal head posture, which, has a normal curve. You can see in that first picture, there's very little red. That red, as it goes on to mild, military, and kyphotic, that's actually the vagus nerve and the surrounding musculature that would put tension on the vagus nerve. So in a normal head posture, you see that there's really little tension or inhibition of the vagus nerve. As we go into more of a forward head posture, you see that there's just more tension on that spine. And remember, I told you, you can put your hand on the base of your neck where the hairline ends, and you can literally trace it. This is how you would trace it around the neck, down to the heart and down to the gut. So when you see someone that comes into your office, man, they've got just this terrible head posture, you could literally, and it'd be eye-opening for them to have them like, hey, what I want you to do is take a breath and just don't even mention their posture. Just tell them, take a breath. And then you could have them, hey, I want you to sit up, nice and tall, get your head back over your shoulders, because that's proper alignment, ears in line with your shoulder. And I want you to take another breath in for me. And if you guys even did it right now, lean forward, take that breath, sit up nice and tall, take that breath, you'll see you actually get more oxygen in with a proper head posture. So you can assess this just through posture. And then there's the infrasternal angle. I love this because I see a lot of prenatal and peds in my office chiropractically. And just to give you an idea, this is what I'm going to mention. So you see this infrasternal angle has to do with rib flaring. So go over to this picture of the three people. You see the rib, the diaphragm kind of like outlined in red, top and bottom. And you'll see the one that has the most rib flare. So think of a pregnant woman. And from early stages, not just when they start showing, there is expansion happening in that body from, first trimester. Things are stretching. And so imagine they go 9 months in this flared rib state, right? And with that, there's so much additional tension as that vagus nerve runs through that diaphragm. There's so much tension on that vagal tone. They do have more shallow breathing. They get out of breath really easily. And yes, there's hormones involved in that too, but just pay attention to this posture. And so can you just imagine with me for a second, why when women, postpartum have such higher rates of, like immediately postpartum, higher rates of anxiety and depression? Could you not imagine that, man, if their autonomic nervous system has been dampened from this tension in their bodies for 9 months, and then imagine a mom who's breastfeeding their child and has this forward head carriage and forward shoulders. Yes, the anxiety and depression is going to go up because there's this lack of regulation that's happening in their body. And so I just will say this once, but this is the important for all moms that, after their pregnancy to experience some kind of pelvic floor retraining, because it's not just for those people with prolapses, or some kind of hernia that they cannot repair naturally. This is to get everyone back into that proper, core pelvic floor optimization so that they can control their autonomic nervous system a little bit better. So, man, you can just do this through postural analysis. And then here is, I put this in a chart because I think it would be a lot easier for you guys to, again, snap a picture, and I don't want to spend too much time because we have a little bit more to go over. But here are some additional assessments that you can do in your office for vagal tone, gag reflex, watching the soft pellet, elevation. I literally walk you through these if you don't know how to perform them, but you do like the gag reflex, with a cotton swab or tongue depressor, and you're watching, that gag reflex. If you don't know what that is, that's a change or brisk elevation of the soft palate and contraction of the pharyngeal muscles around it. So there should be a normal vagal tone response with that. But you can see a weakened one where you get, uvula deviation or lack of change in the soft palate and pharyngeal muscles, and it can be one-sided. So I think I note that in the say-ah test, how the uvula can deviate to the intact side. So intact meaning intact side of the vagal nerve. It deviates to that. So these are little things you can check in your office. Again, take a picture if you need to. I'm not going to have time to go through all of them, but so important. Like I said, you can check the posture. You can check the breathing rate. Is it shallow? Is it deep? Is it rapid? Check their sweat response. You may literally, I mean, as a chiropractor, we're putting our hands on patients, so I can feel, sweat and goosebumps, and I can tell what state their autonomic nervous system is. And then you can also do the Valsalva maneuver down there. So I'm going to jump to the next slide just for sake of time. So how do we stimulate the vagus nerve? So first, there are, kind of those invasive stimulators that you can basically have put in they still do them. There's definitely still, these vagal nerve stimulators that are transplanted into the patient, and they literally help stimulate the vagus nerve, but they're kind of less utilized outside of those like epileptic, depression, stroke rehabilitation patients, because there are so many side effects that come with them. So, you can definitely go down that route if it's a severe patient that you think, is suffering from these types of symptoms. But nowadays there's a lot of the more non-invasive, which is probably the type of patients y'all are seeing, where you can literally just put them on like the side of the neck. You can, there's ones that wrap around the ears. They look like headphones, and they're stimulating behind the ears, the vagus nerve. But again, the ones that you hold on the side of the neck. And these are not as well researched. As you can see, the FDA does approve them for like cluster headaches and migraines and a lot of more head pain issues, but they're not really FDA approved quite yet for just overall wellness. But then there's the ones, like I mentioned to you, that you can buy over the counter that, again, aren't FDA approved, but they're out there. There's just not a lot of research on them for them to be FDA approved yet, but we are seeing them definitely causing changes. So let me jump to the next slide and I'll explain. In POTS, so this is awesome. So POTS is basically your postural orthostatic tachycardia syndrome. So it's a condition of basically orthostatic intolerance. So essentially, we all, or maybe if you're not there, I'll inform you that there is a state of like systemic inflammation. There's a systemic inflammatory response that is well known with POTS, and it's this inflammatory cytokine, inflammatory response that we all know kind of comes with POTS. And so, what I want you to understand is stimulation of the efferent vagus nerve by these transcutaneous vagal nerve stimulators. They have been shown to attenuate that systemic inflammation and also an immunomodulatory effect of the parasympathetic state in the spleen. We talked about that splenic nerve pathway that's known to be responsible for this anti-inflammatory activity, in POTS. I think that that's so fascinating. So you can actually see, with these stimulators, a change in the inflammatory cytokines, that pathway that's triggered with POTS. You can see a change in the pathophysiological process of vasoconstriction, central sympathetic flow, and promotion of appropriate sinus tachycardia. Like we're seeing that, in some of the studies. Nothing is, I think, validated just yet for that, but I mean, we're seeing that it can really help. So again, something to consider in these patients that just have no answer for these symptoms. And then I've got daily stimulation of vagus nerve. So this is kind of a little bit more like, hey, if I want to give my patient something tomorrow that they can do, I can have them do these things at home, practicing the diaphragmatic breathing, meditation, singing or humming. Oh my goodness. I mean, I have an 8-month-old, baby who I put to sleep, and she will sigh. What's interesting is the vagus nerve is known as your soul nerve. It's a kind of how you connect to other people. And so she'll put her little head on my chest and she'll hum. She kind of hums, and I can sense myself that she's putting herself kind of into this regulated state, but humming back to her, man, she falls asleep. You watch her shoulders, they just relax. So you can, this is so amazing that you guys, to realize that you can regulate yourself. Like even as a clinician, maybe you guys want to be doing some of this before, your patient visits, because if you regulate yourself, you can also actually communicate through that soul nerve or the vagus nerve to help your patients regulate theirs as well. And then there's some apps like Nerva is a good one that I was informed about. I have not used it myself, but I have been informed about. that really does help kind of through hypnotherapy get more in tune with your body, and it really walks you through. So if you're also a clinician who's like, I don't have time to get my patients more aware of their body, that's fine. There's so much at your fingertips to help educate them on these autonomic nervous system responses. And then that's the thing, is they do the work for you. Then your patient comes back and you're like, oh, doc, man, I noticed I had this sweat response in the meeting at work, and then I started breathing shallow, and man, my vision changed, and it's like, oh, thank you. You just told me exactly what was going on. So it really, the more you empower your patients, it really comes back to help you in the end. And then there's the vagal nerve diet, which, funny enough, there's no such thing as a vagal nerve diet. It's not like, your latest keto diet or anything like that. But I put this up here because it's just going to remind you, we saw it in the GI map. We want a diet that is very rich in probiotics, specifically that lactobacillus, bifidobacterium, short-chain fatty acids, and then anything that's pro-inflammatory is going to help this vagal nerve. So choline-rich foods, omega fatty acids, polyphenols. This is the type of diet that you want your patient to focus on, especially if you notice in their GI map some vagal nerve deficiencies. So summary takeaway, we talked about the bidirectional pathway here. We talked about some of the pathologies that you're probably going to see in your clinic, the functional dyspepsia, the IBD, even GERD, but that typically comes with H. pylori. Some of the symptoms that they're going to report to you, hey doc, I've got bloating, inflammation, pain, that kind of thing. And how you can identify those guys in the patterns on our GI map. So yes, you're hearing it from them, but then identifying it in diagnostic imaging. What I want you to be able to do in clinic next day is assess posture. Look for those cues that they're telling you about sympathetic, run from a bear, versus parasympathetic, rest and digest, and be able to give them something to take away that day in clinic. So this is just a brief summary, just to kind of recap everything we went through in detail. And then I'm going to go to the next page real quick. Obviously, we've got our diet and apps that we can use to help them as well. But real quick, what I'm going to show you guys is a quick GI map, because this is an H. pylori GI map. And this patient complained of excessive belching, bloating, and pain. And what I want to show you is look at this patient. So page 1 was fine. Page 2, there was low levels of H. pylori, not flagged high, but low level. I'd say high normal is what I wanted to say, high normal. And someone might just look past that. A clinician might be like, hey, it's not actually flagged positive, but look at the symptoms. The patient has excessive belching, bloating, and pain. I mean, those are common H. pylori symptoms. But what I really want to draw to your attention is look at this pattern. This is exactly what I'm talking about, how you can identify this in clinic, in your GI maps, is you've got something like H. pylori. You see low normal lactobacillus, low short-chain fatty acid producers like Akkermansia and Fecalli, and Firmicutes. Those are your short-chain fatty acid producers. So you've got someone with H. pylori. They're in that sympathetic state. Then you see these inflammatory overgrowth. So remember, these patterns, you kind of sometimes see a mix of them. And so you've got this sympathetic state, you've got this inflammation, and then just to top it off, you see at the end here, this lack of digestive juices. So their elastase is kind of falling below that functional. Remember, functional above 500. So now their digestive juices are decreasing, and you've got this huge intestinal permeability, triggering to things like gluten, potentially even other foods with how high that SIG-A is. So this huge inflammatory response, and this is that inflammatory response that you kind of look at this and you're like, man, look at the elevation in that SIG-A. Why are they not, why is that? Why is that really just from, the leaky gut, or is that just from these overgrowths? I would say no, that's really, some of that is due to this lack of vagal tone involvement, because you and I both have seen a page 3 where those bacteria are just lit up, all of page 3, and they don't have a high SIG-A or high anti-gliadin. So you really want to hone in on this vagal nerve. And I know that was kind of like a quick case, but you can identify every pattern I talked to you about here on this test with H. pylori. And then I will go ahead and end there.